I would like to provide you with an overall brief summary of transference-focused psychotherapy. That, as I mentioned, is indicated if personality difficulties are a consequence of severe trauma or post-traumatic stress disorder complicates a personality disorder. All of the cases that are called complex post-traumatic stress syndrome and are really personality disorders in which trauma has played an important etiological function, but which are no longer simply post-traumatic stress syndromes and have to be treated with a more specific long-term psychotherapeutic approach. Transference-focused psychotherapy is a modified psychoanalytic treatment. Within psychoanalytic psychotherapy is the one that comes closest to psychoanalysis proper and uses the basic techniques that are common to psychoanalysis, except modifies this basic technique to some extent for the purpose of this treatment, geared to the treatment of severe personality disorders. The objective of transference-focused psychotherapy is to resolve identity diffusion and permit the integration of normal identity with normalization of the integration of self, concept of significant others, and all the improvements in all the psychological functions that should come from that. The treatment is carried out usually on a twice-a-week basis. People have been trying to do it on a once-a-week basis. It's difficult to do it on a once-a-week basis. The treatment doesn't have sufficient intensity to give you all the richness that it offers. It may be carried out with a higher frequency, but it is usually not necessary. So it has a lower frequency than psychoanalysis proper. It is carried out in face-to-face sessions, usually each of 45 or 50 minutes sessions that varies from place to place. And is a precondition, is a working instrument for carrying it out. The patient is instructed to do free association, while the therapist carries out an evenly suspended attention to everything the patient is producing. The method of free association is explained in great detail in all cases, telling the patient that he's supposed to say whatever comes to mind without any critical attitude, trying whether without considering whether what comes to mind is important, unimportant, good, bad, interesting, boring, frightening, something to make you feel proud, whatever. The patient is invited not to have any preset agendas, to come totally unprepared as much as he can to the session. Obviously, the symptoms and the difficulties that worrying the patient will come to mind easily, and that's perfectly appropriate. But he shouldn't try to organize it, but let it flow freely. And he should spell it out, whether it seems good or bad, with total freedom, including total freedom of thoughts, feeling about the therapist and about the treatment situation. It is really the highest potential degree of freedom one can have to say what is on one's mind. That's the role of the patient. We tell the patient that it will take some time to learn this, and the therapist will help the patient to learn it. And indeed, it takes some time at first. If the patient is told, it may seem strange to him, because sometimes what comes to mind may come in the form of questions, wishes to establish a dialogue with the therapist, and the therapist will not establish a dialogue, but treat what comes to mind as the surface manifestation of what are deeper unconscious content that the therapist hopes to discover on the basis of listening to the patient pre-association. And the therapist's task will be to listen attentively, contribute to the patient whenever he has something to contribute to the patient's understanding. And the role is to be an interested observer, but staying outside the activation of particular transference demands and expectation of the patient. The therapist acting with evenly suspended attention pays equal attention to the content of what the patient is saying, to the patient's non-verbal behavior, and to his countertransference. And on the basis of listening to the verbal content, the non-verbal content, and the countertransference of the therapist will diagnose the dominant conflict now being activated and spell it out to the patient, helping the patient further bringing to consciousness this conflict. Bion has suggested that the therapist operate without memory nor desire, by which he means that the therapist should not have preset ideas what needs to be interpreted on the basis what he knows from before of the patient, let himself totally be carried by what's coming up now, and without desire in the sense of being open to help the patient understanding without wanting to move the patient into any particular direction. That seems a right way to starting out the session, but in the session itself, it will of course be impossible not become involved with memory aspect of the patient and with the therapist motivation to help the patient clarify and deal with the conflicts that come up in his mind. So the assumption is that in carrying out pre-association and even the suspended attention or analytic listening, something will acquire affective dominance. In other words, will become affectively most important in the here and now of the session. That is what is focused upon by the therapist with an effort to clarify as quickly as he can in this activated affect who has the role of subject, who has the role of object, who has the role of emitter of the affect, who has the role of receiving the affect. In other words, the therapist tries to assess the object relationship behind the affect activation. And the dominant object relationship is interpreted as that level of the patient's internal conflict that can be influenced at this point. This means in practice that there will be one dyadic relation that will be on the surface and that has the function to avoid an opposite one that the patient is dissociating or inhibiting or projecting or repressing. So that the dominant object relation, what appears first is seen as a defense against a deeper one that reflects the impulse. And we have to first clarify the defense fully before we go into the content, the impulse. And the treatment consists in a systematic analysis of all the internalized object relations that sequentially appear in the sessions with the purpose of reconstructing in that sequence the nature of the dominant, unconscious, or dissociated conflicts that determine the patient's difficulty, particularly his characterological difficulties.